Before you consent to any operation, there is one question every older adult should pose to their physician, but surprisingly, most never do. And neglecting to ask it could leave you dealing with risks, complications, or a recovery that ends up very different from what you anticipated. If you are past the age of 65, surgery impacts your body differently than it did years ago, which makes the questions you raise beforehand more critical than ever. In today's video, we will uncover the 4 essential questions every senior should pose before surgery, including the one question that could entirely shift how you think about the procedure itself. These questions can help you better grasp your options, safeguard your brain health, and prepare for the recovery ahead. I specialize in cardiovascular health and aging, and the pattern I consistently observe in my work with adults over 60 is this. People walk into a surgeon's office already assuming the surgery is decided. The conversation never occurs. The questions never get raised, and sometimes that costs them in ways nobody anticipated. These 4 questions cost nothing to pose. You do not need to be a medical expert. You just need them written on a piece of paper. We are counting down from 4 to 1. And I want you to stay for number 1 because that is the question most people never think to pose, and it is the one with the most power to change what happens to you. Question number 4. Doctor, do I actually need this surgery right now, or is there a non-surgical alternative? There is a difference between a surgeon saying surgery is the recommended path and surgery being the only path. Most patients over 60 never recognize that distinction exists until after the fact. Advanced physical therapy, not basic stretching, but targeted progressive programs, has delivered real results for joint and soft tissue conditions that once had surgery as the automatic first response. Targeted injections, activity modification, pain management protocols. There are entire branches of conservative care that some surgical offices simply do not lead with. Not because they are concealing them, but because a surgeon's training is built around surgical solutions. That is not a criticism. That is how specialization functions, which is precisely why you have to be the one to ask. Beverly, 71, was scheduled for a knee replacement. 3 years of pain, a limp, could not finish a grocery trip. She came in for pre-surgical cardiovascular clearance and mentioned almost casually she had never completed more than a few physical therapy sessions. I recommended a structured 8-week program before committing to surgery. 8 weeks later, she contacted my office and said, "Doctor, I walked my granddaughter to school this morning and didn't think about my knee until I got home. She has not needed surgery yet. Write it down." Question 4, pose it before you agree to anything. Now here is where most people assume the greatest risk is physical. The incision, the recovery, the pain. But what if surgery is not actually the greatest risk? Because the next question involves something many seniors dread even more than the operation itself, and almost nobody raises it. Question number 3. What precisely happens to my physical health if I choose not to have this surgery? This is the most undervalued question on this list. By the time most seniors are sitting in a surgeon's office, they have already framed this as surgery versus living with the pain, but that framing is incomplete. The real question is, what is the actual medical trajectory of this condition, if managed conservatively? Because sometimes the honest answer is, it will deteriorate and waiting makes surgery riskier. In that case, moving forward now is the right decision. But sometimes the honest answer is, this condition is uncomfortable but stable, and you have a window to try other approaches. And in that case, you have more time and more options than you realized. Ask specifically, will this condition worsen if I wait? Is there a point where the window for conservative management closes? Give me the medical picture of both paths, surgery and not surgery, so I understand what I am actually deciding between. Gerald, 68, came in after being informed he needed spinal surgery for stenosis. He was frightened, and he had stopped raising questions in those appointments altogether. When we structured what to actually say, he went back and asked his surgeon directly, "What happens medically if I try 12 weeks of aggressive physical therapy first?" His surgeon, a good one, explained his specific stenosis was not the rapidly progressive kind. There was a real window. Gerald took that path. It helped significantly. He made that decision with full information, not fear. That question protects your body, but the next one protects something just as important, and it is the one your surgical team will almost never bring up on their own. What I am about to share is the part most seniors discover only after surgery, and by then it is too late to prepare for it. Question number 2. What is my specific risk of memory problems or confusion after anesthesia? Roughly 50% of adults over 70 who undergo major surgery under general anesthesia experience post-operative delirium, confusion, disorientation, memory gaps in the days following the procedure, and a meaningful portion go on to experience lasting cognitive decline, slower thinking, difficulty concentrating, memory issues that persist for weeks, months, or sometimes longer. This happens to sharp, alert, fully independent adults who went in feeling completely fine. The older brain simply processes deep sedation differently. It takes longer to clear the anesthetic agents. Add surgical inflammation, disrupted sleep in a hospital environment, and the disorientation of waking up in pain in an unfamiliar room, and the brain is under a combined load that does not always resolve on the same timeline as the body. What seniors actually need to understand is simple. Will I still feel like myself afterward? And the answer to that question depends on factors your surgical team can actually control if you ask. Anesthesia protocols can be customized. Regional anesthesia or nerve blocks can sometimes replace or reduce general sedation. Lighter agents with faster clearing profiles can be used. Brainwave activity can be monitored in real time during the procedure. None of these options will be offered automatically, but ask specifically, given my age and this procedure, what will the team do to protect my cognitive function? And a good anesthesiologist will have a real conversation with you. This question is not about refusing anesthesia. It is about making sure the people putting you under recognize that your brain matters as much as your body. Here is something most people only learn after surgery, when it is already too late to act on it. Medicare and most supplemental plans cover home health aid services post-surgery, but only if your physician orders it before discharge. If you did not request that order before the procedure, and you are already home struggling, arranging covered care becomes significantly harder. One conversation before surgery, prompted by the next question, can mean the difference between having covered help in your home for the first 2 weeks of recovery and paying out of pocket, or going without entirely. Before we get into number 1, I want to ask you something directly. If you have already been through surgery, or you are supporting someone going through this right now, what is the one thing you wish someone had mentioned to you before it happened? Drop it in the comments below. Someone watching this video right now is in that waiting room mentally and has not found the words for what they are feeling yet. Your experience might be exactly what they need to hear. Question number 1. Of all the questions we have discussed today, this is the one I would pose first if someone I loved were heading into surgery tomorrow morning. Will I honestly be able to live independently and take care of myself after recovery? This is the question that strikes closest to what seniors actually fear. Not the surgery, what comes after it, whether you will return to the life you had, whether you will need someone in your house, whether you will become, and this is the word that sits in the back of the mind even when nobody says it out loud, a burden. That fear deserves a real answer. Not reassurance, not a pamphlet, a specific, honest picture of what recovery looks like for someone your age after this specific procedure. Here is what that picture actually includes. After 65, muscle loss during a period of surgical bed rest is faster and more significant than most people expect. Adults over 65 can lose up to 10% of lower body muscle mass during just 1 to 2 weeks of reduced mobility. That muscle does not return on its own, and it returns more slowly than it did at 45. The recovery timeline your surgeon provides you, 6 weeks, 8 weeks, is often the timeline for the incision to heal. It is not necessarily the timeline for you to feel like yourself again. Patricia, 74, was a retired nurse, medically knowledgeable her entire career. She went in for laparoscopic gallbladder surgery, routine, minimally invasive, and assumed she understood what recovery looked like. What she did not account for was how the anesthesia fatigue and 1 week of reduced activity would affect her balance. She lived alone. She had not arranged for anyone to stay with her. By day 4, she was back in the ER, not from a complication, but from a fall. She was fine, but she told me afterward, "I spent 40 years as a nurse and never thought to ask whether I'd actually be okay by myself." Ask specifically, what support will I need at home and for how many weeks? Will I be able to manage the stairs, drive, cook? What does week 1 actually look like? And ask your doctor to include a home care order in your discharge plan if your situation warrants it, because that order is the key to covered Medicare benefits. Here is what to do before you go to bed tonight. Write these 4 questions on paper, not your phone, on paper, and put them with your medical paperwork. That is your commitment. Walk into your next surgical appointment with those 4 questions, and do not leave until every one of them has a real specific answer you can repeat back. 30 days from now, you will be in a fundamentally different position than most seniors facing this decision. You will understand what you are actually choosing. If this video helped you think differently about how to advocate for yourself, subscribe. Because next week we are covering the 1 blood pressure number your surgical team should be tracking before any procedure that most pre-surgical screenings miss entirely. If you are heading toward any kind of surgery, that video matters. Take care of yourself and take care of each other.